And we can go ahead and get started.
Okay, sounds good. So good afternoon, everyone. So it looks like it's 5 p.m. in Denver, 4 p.m. in California, 6 p.m. in New York. So I'm so happy to see many of you with us this afternoon. This is Fida Obeidi, and I serve as the Dean for the Center for Health and Natural Sciences at the Community College of Denver. We are hosting those cannabis workshop series in preparation for our Cannabis Business Associate degree and Cannabis Science and Operations Bachelor of Applied Science degree. It is with a great pleasure for me. It is a great pleasure for me to introduce our speaker this afternoon, who is going to talk to us about cannabis and the cardiovascular disease. Our speaker today, if you don't know, is the President and Chief Education Officer of Radicle Health. Please join me in welcoming Mr. Timothy Byars. Timothy, it's all yours.
All right, thank you, Dr.
Welcome, everyone.
Welcome, everyone, and thanks for attending. Again, this workshop is a collaboration between the Community College of Denver and Radicle Health, and today we are going to talk about cannabis and cardiovascular disease. And if it looks like my attention is being diverted, I'm still letting people into the meeting from the waiting room. It should die down as we get a little bit further into the discussion. So again, my name is Timothy Byars. I'm the President and Chief Education Officer of Radicle Health. I've done some other stuff too. If you're so inclined, you can review this bio in the recording or at our website at radicalhealthcare.com. I'd like to make this lecture as interactive as possible. So I'm going to occasionally pause for questions, but also you can use the chat. I have the chat open, so I'll try to keep an eye on that. Or you can click the raise your hand button, and when that happens, it moves your picture up to the top, so I'll be able to see if you raise your hand as well. This presentation is for educational purposes only, and the information presented is not intended to be a substitute for medical advice. This information is not meant to help in the diagnosis, prognosis, or treatment of cardiovascular or any other virus, disease, illness, or condition. Cannabis can affect your INR levels. We're going to talk about what that is later in the presentation, and can put you at risk for increased bleeding and bruising. So tell your primary care physician if you're using cannabis with warfarin, and monitor for changes in your prothrombin. This is a protein that causes blood clotting. Notify your warfarin clinic if you intend to start cannabinoid therapy, and monitor for any signs of bleeding. I am not a healthcare professional. If you need healthcare advice, please get your healthcare advice from a licensed healthcare professional and not from a man who has a degree in English literature. So early in August of 2020, the American Heart Association released a comprehensive statement about cannabis and cardiovascular health, and that it was titled Medical Marijuana, Recreational Cannabis and Cardiovascular Health, a scientific statement from the American Heart Association. And while they did acknowledge that cannabinoids have, quote, potential therapeutic and medicinal properties, they also stated this. They said, quote, cannabis may have therapeutic benefits, but few are cardiovascular in nature. Conversely, many of the concerning health implications of cannabis include cardiovascular diseases, although they may be mediated by mechanisms of delivery, end quote. As you can imagine, the resulting internet headlines were both breathless and alarming. Weed is not good for your heart, studies say. Millions of cannabis smokers at risk of deadly heart attack and stroke. Docs warn. American Heart Association warns marijuana is a substantial health risk. Smoking, vaping cannabis could trigger heart attacks. And my favorite, could marijuana break your heart? So the literature, the medical literature produced in the last 30 years about cannabis and cardiovascular disease is somewhat overwhelming, especially if you're not a cardiologist or if you don't have a background in cardiovascular disease. It does mostly consist of case study reports, things like letters to the editors, and then there are a few large observational studies. So let's start with this. Let's start with what we know. We know that combusting cannabis flower can have multiple negative effects that can lead to cardiovascular stress and potentially more serious issues in persons with existing cardiovascular problems. So these These issues include increased heart rate or tachycardia, increased myocardial oxygen demand, decreased myocardial oxygen supply, increased carboxyhemoglobin levels, and increased endothelial dysfunction. Now, these risks are mostly related to smoking organic combustible material, but I do want to review and define each one of these risks. So tachycardia, what's tachycardia? It's a condition that's characterized by rapid heart rate. So generally for adults, a heart rate of more than 100 beats per minute is considered too fast. 60 to 100 beats per minute is considered normal. And when the heart beats too rapidly, it pumps blood less efficiently. And this reduces the blood flow and subsequently the oxygen to the rest of the body, including the heart muscle itself. Because the heart is beating more rapidly, the muscles of the heart are required to work harder and they need more oxygen. So persistent tachycardia can lead to oxygen-starved cells in the heart, and this can lead to a heart attack. Now we know that THC can produce tachycardia, especially in cannabis-naive consumers. THC might produce tachycardia via CB1 receptor activation in the heart muscle itself, or THC might produce tachycardia because it can stimulate the sympathetic nervous system. So recall that the sympathetic nervous system modulates involuntary responses to dangerous and stressful situations. We know this as our fight or flight mechanism. A stimulation of the sympathetic nervous system can increase heart rate, it can increase blood pressure, and it can increase oxygen demand. So what are myocardial oxygen demand and supply? Like any tissue in the body, the heart muscle requires an adequate blood supply and adequate amounts of oxygen for optimal function. So myocardial oxygen demand is the amount of oxygen that the muscular tissue in the heart requires to work properly. And myocardial oxygen supply is the amount of oxygen that the heart receives from blood delivered by the coronary arteries. So under normal conditions, myocardial oxygen demand equals the myocardial oxygen supply. Now, heart rate is one of the most important factors affecting myocardial oxygen demand. And when the heart rate increases, the heart's muscular tissue's got to work harder. It's got to pump blood to the rest of the body. We know that THC can produce tachycardia, and this increases heart rate and therefore increases the oxygen demand of the heart muscles. When blood flow to the heart is reduced and prevents the heart muscle from receiving enough oxygen, it's called myocardial ischemia. So if the heart muscle doesn't receive enough oxygen, this condition can eventually lead to heart attack, and that's going to destroy part of the heart muscle. It can also lead to an irregular heart rhythm. This is an arrhythmia. This can also weaken the heart, and in some cases it can be life-threatening. And over time, ischemia can lead to heart failure. All right, what about carboxyhemoglobin levels? Remember that these can be raised when you're combusting organic material. So red blood cells carry millions of proteins called hemoglobin, and these proteins facilitate the transport of oxygen throughout the body. As oxygen molecules bind to sites in each hemoglobin protein, there are 4 places where oxygen can bind on each hemoglobin. And under normal circumstances, oxygen binds to hemoglobin in the alveoli. So you breathe in, oxygen goes into your lungs, it goes into your alveoli, and then it gets carried via the hemoglobin to the rest of the body, and the oxygen gets released where it's necessary in the body. When you smoke cannabis, or I should say when you combust cannabis or burn and inhale any organic material, the combustion can produce toxins. Tars and carbon monoxide, for example. So carbon monoxide is colorless, it's odorless, it's poisonous. And when inhaled, carbon monoxide can bind to hemoglobin in the red blood cells, and this forms carboxyhemoglobin. So in fact, carbon monoxide binds to hemoglobin approximately 200 times more efficiently than oxygen. And because it binds so tightly, there's a slow rate of release and there develops an accumulation of carboxyhemoglobin. So subsequently, fewer hemoglobin proteins can bind to oxygen, and that reduces the amount of oxygen that reaches the organs and the muscles in the body. So carbon monoxide poisoning has been associated with a number of cardiovascular issues. including cardiomyopathy, angina, acute myocardial infarction, arrhythmia, cardiac failure, pulmonary edema, and also sudden death. Now, I'm assuming that most people on the call are probably not cardiologists, so I do want to just quickly define some of these conditions. So cardiomyopathy, there are different types of cardiomyopathy, but all of them are diseases of the heart muscle that essentially makes it harder for your heart to pump blood to the rest of your body, and this can eventually lead to heart failure. So, for example, there's one type that's characterized by the enlargement of the left ventricle. There's another type that's characterized by abnormal thickening of the heart muscle, but essentially they all hinder the ability of the heart to work properly and to pump blood properly. Angina is a type of chest pain that's caused by reduced blood flow to the heart. Acute myocardial infarction, this is a heart attack. And of course, heart attacks are life-threatening. This occurs when blood flow to the heart muscle is abruptly cut off. Arrhythmia, we've mentioned already, it's a irregular heart rhythm, but this can also weaken your heart. In some cases, it can be life-threatening. Cardiac failure, you might hear this as congestive heart failure. This is kind of a more general term for the chronic condition where the heart doesn't pump blood as well as it should. And then pulmonary edema is actually a condition characterized by excess fluid in the lungs, and the fluid collects in the alveoli, in the air sacs, and it makes it difficult to breathe. And in most cases, heart problems cause pulmonary edema. All right, what about endothelial dysfunction? Remember that smoking or combusting any kind of organic material can also increase endothelial dysfunction. So a common predecessor to cardiovascular disease is damage to the vascular endothelium. Now, the vascular endothelium is a single layer of cells that makes up the inner lining of our blood vessels. And damage to this lining can impair its function, and it causes a condition called endothelial dysfunction. And it's characterized by impaired vasodilation, so your blood vessels can't expand properly, by inflammation and by blood clotting. So preventing damage to the vascular endothelium can minimize the risk of developing cardiovascular disease, including heart attack and stroke. Any type of smoking can damage endothelial cells. Also, and it's not yet thoroughly understood, but it seems that it's possible that chronic activation of CB1 receptors might also contribute to endothelial dysfunction as well, but the research is far from conclusive here. Again, it's important to note that these are risks that are associated with smoking any organic combustible material. So we also want to explore whether the use of cannabis and cannabinoids specifically potentiate adverse cardiovascular events. And so we can take a closer look at the research that's available. So if you do a simple internet search using the terms cannabis and heart attack, you will likely return information quoted from a study completed in the year 2000, in which researchers determined that the risk of a heart attack is 4.8 times higher in the first hour after smoking cannabis. This is a study that is ubiquitous on the internet. It's on websites like Healthline, the American Heart Association, the American College of Cardiology, BBC News, Harvard Medical School's website, the CDC's website, CNN. It's referenced in the National Academies of Sciences, Engineering, and Medicine's comprehensive report from 2017. It's been on ABC News, on MarketWatch, and it's quoted in multiple published medical papers. Again, 4.8 times the risk of a heart attack during the first hour after smoking cannabis. That's an alarming statistic. The details of the study, however, present a somewhat less salacious conclusion. The study was led by Murray Middleman. He's at Harvard Medical Center, and it included 3,882 patients interviewed between August 1989 and September 1986. September 1996. All of these subjects had heart attacks. Of these 3,882 patients, 124 of them reported smoking cannabis within 1 year of their heart attack. 37 of those patients reported smoking cannabis within 24 hours of their heart attack, and 9 patients reported smoking cannabis within 1 hour of their heart attack. Now, 3 of these 9 patients reported smoking cannabis, but also reported cocaine use and sexual intercourse within 1 hour of the attack. So Subsequently, the conclusions of this study are based on 6 patients. And even if we assume that Dr. Middleman's conclusions are correct, smoking cannabis would still account for a smaller proportion of heart attacks than air pollution. Now, in response to the Middleman study, the Lynn Smith Center, this was the predecessor to the Drug Policy Alliance, they published an article called Junk Science Makes Headlines, Questionable Study Links Marijuana Smoking and Heart Attacks. They published this in June of 2001. And they stated the following, quote, "An analysis of the research methods used reveals glaring flaws. The sample size is statistically insignificant. No causal relationship has been established, and the study itself has never been replicated. Based on this minuscule self-selected sample, Dr. Middleman concludes that the risk of a heart attack is 4.8 times higher after smoking marijuana. The sample size alone renders the results meaningless, and assuming that Dr. Middleman's conclusions are correct, the fact that heart attack risk for an otherwise healthy 50-year-old man is about 10 in 1 million highlights the sensationalism of the widespread publicity the study is receiving," end quote. Another statistic that appears consistently in internet articles and in the medical literature is that in patients with chronic stable angina, smoking a single cannabis cigarette decreased exercise time to angina by 50%. So in other words, people with existing angina will feel chest pain sooner if they smoked cannabis before exercising than they would if they did not smoke cannabis prior to exercise. Again, this is a oft-cited statistic that seems to be taken as an acknowledged fact. And yet, this statistic is cited from a single study. It was completed in 1977. It included 10 male patients who were asked to smoke 18 milligrams of THC. Now, this is a very small sample size, a very high dose of THC, and yet the information is presented in the medical literature as putative. Now, this is a study, this is the Cardia Study. This is the coronary artery risk development in young adults. It's a long-term study of cardiovascular disease beginning in young adulthood. A very well-respected study. It included over 5,000 adults aged 18 to 30 at the beginning of the study. This was in 1985 and 1986. So researchers at the Cardia Study followed these participants for nearly 30 years, and they estimated cumulative lifetime exposure to cannabis with assessments that they collected at examinations every 2 to 5 years. Now, the study intended to examine the incidence of cardiovascular disease in this patient base. Now, researchers concluded that compared with no cannabis use, cumulative lifetime and recent cannabis use showed no association with cardiovascular disease, stroke, heart attack, coronary heart disease, or cardiovascular disease mortality. Cannabis use was not associated with cardiovascular disease when stratified by age, gender, race, or family history. There's a different team of investigators at Harvard Medical School and Beth Israel Deaconess Medical Center. They collaborated on a prospective study to assess the use of cannabis among patients with existing heart disease and whether cannabis use is associated with an increased risk of death. Now, this study included nearly 4,000 heart attack survivors. They were studied over an 18-year period. Here are their conclusions. Quote, "In this prospective multi-center cohort study of myocardial infarction, survivors followed prospectively for up to 18 years. There was no conclusive evidence of an association between smoking marijuana and mortality," end quote. Madeline Meyer and her colleagues at Duke and Arizona State University, they published a longitudinal comparison of persistent cannabis users with tobacco users. And they used data from roughly 1,000 individuals who were born in Dunedin, New Zealand between 1972 and 1973. And this was a study, the Dunedin study is a study where they followed these participants for decades. So Meyer and her colleagues wanted to test how cannabis use between the ages of 18 and 38 was associated with physical health at age 38, even after controlling for tobacco use, childhood health, and childhood socioeconomic status. Now, they found that tobacco use was associated with worse lung function and worse metabolic health, and also systemic inflammation at age 38 years. So no surprises, right? Regarding cannabis, they stated that cannabis use for up to 20 years is associated with periodontal disease, but is not associated with any other physical health problems in early midlife. Now, there are, of course, some studies that seem to suggest an association with cardiovascular risk and cannabis use. But they tend to be isolated case reports, or they tend to be larger studies that include confounding factors, things like tobacco or illicit drug use. So for example, a very large study published in 2013 suggested an association between, quote, a cannabis lifestyle that includes tobacco, end quote, and ischemic stroke. Now, of course, demonstrating an association is not the same as proving causality. And in this study, nearly every patient with a positive cannabis screen also tested positive for tobacco use. So the researchers in this study noted that, quote, further research is required to clarify whether there is an association between cannabis and stroke independent of tobacco, end quote. This is a case report that was published in 2014. This report described a healthy 21-year-old man who had reported to the emergency department in Wales. This was in Great Britain. He had a sharp pain in his chest that began while he was playing soccer. It lasted 30 minutes. He had a heart attack. And while he was both a regular user of both cannabis and tobacco, he had also reported cocaine use, but he said that his cocaine use was not recent. For some reason, doctors identified his cannabis use as the most significant precipitant of his attack. And here's part of the reason why they came to that conclusion. They say, quote, though cannabis is not commonly regarded as a risk factor for this diagnosis, there is evidence that cannabis seems to be a rare trigger factor for myocardial infarction, with the risk being increased by a factor of 4.8 in the first hour after smoking it. So apparently, these researchers and doctors also read the Middleman report. The National Institute on Drug Abuse performed a seminal review. This was co-authored by their director, Nora Volkow, and this was published in the New England Journal of Medicine in 2014. So NIDA summarized the existing medical research and identified their overall confidence in the evidence of adverse effects of cannabis. Now, certainly one can take issue with these estimations of confidence. That's a different talk for a different day. What's notable, however, is what's not listed here, and that's cardiovascular risk. This underscores the fact that there is a great deal of ambiguity about the data and the association between cannabis and cardiovascular risk. So at this point, I've mostly focused on cannabis-related cardiovascular risk that's related to smoking. So, we have to ask the question, are there risks associated with other routes of administration? There is a case study that was published in the Canadian Journal of Cardiology. It was a 70-year-old man with a history of heart disease. He wanted to reduce his osteoarthritic pain and improve his sleep. So he consumed a cannabis edible that contained 90 milligrams of THC. That's 90 milligrams. And as predicted, within 30 minutes, he experienced hallucinations and severe chest pain. So at the hospital, the doctors determined that he had had a heart attack, and they stated that they believed that the large dose of THC put a sudden and unexpected strain on his heart and triggered the attack. It's well established that ingesting cannabis can produce acute anxiety, panic attacks, and tachycardia. And all of these symptoms can strain the heart muscle, especially in patients who have existing cardiovascular disease. It's especially important for senior patients and for patients with existing cardiovascular disease to work with a healthcare professional and to ensure that they're using an appropriate cannabinoid profile, the best route, and an appropriate dose. I also want to mention that there have been at least 4 published case reports of myocarditis associated with cannabis use. And in one case, the condition led to heart failure and the subsequent death of an 11-month-old child who ingested cannabis edibles. So myocarditis refers to inflammation of the heart muscle. It's typically caused by the immune system, and it's typically caused in response to some trigger. And it's usually a viral infection or a chemical toxin. So in all of these reports, it's not clear whether the cannabis itself was the cause of myocarditis, or if there were contaminants in the products that contributed to the condition. The report doesn't state where these subjects were, or where they bought their products, whether they were in legal markets or if these products were bought off the illicit market. So it's impossible for us to know whether they contain pesticides or mold or heavy metals, or whether the patient had some existing and unidentified condition that was exacerbated by extremely large doses of cannabis. So clearly the risk of using cannabis, especially if you're combusting cannabis or ingesting large doses, that risk is not zero. But the overall effect of cannabis use on the frequency of cardiovascular events remains at best unclear. That said, I think that the research does suggest that cannabis will likely not cause cardiovascular disease or heart attack in a healthy person. And while there are small studies and individual case reports that suggest that cannabis can trigger heart attacks in people with existing cardiovascular disease, that risk remains low, especially if they're using routes other than inhalation or taking appropriate doses. And cannabis, and specifically THC, can produce side effects. It can produce adverse effects, tachycardia, hypertension, and vasoconstriction with initial use. And while these are side effects that are dose dependent, and some users will develop a tolerance to these adverse effects, patients with underlying cardiovascular use should discuss use with their healthcare professionals. I do want to note here that the Canadian Federal Department Health Canada has also weighed in on the evidence examining the effects of cannabis on cardiovascular health. And they state basically that it's inconsistent and insufficient. They said this, quote, "While cannabis is known to cause peripheral vasodilation, postural hypotension, and characteristic conjunctival reddening after smoking," that's red eyes, "the most consistent acute physiological effect of smoking cannabis is dose-related tachycardia. While cannabis-induced tachycardia is not usually considered dangerous for healthy young users, it may be dangerous to those already suffering from cardiac disorders or from angina," end quote. Quite recently, researchers concluded a comprehensive systematic review of the literature published between 1975 and September 2017. And these were their conclusions. You can see them on the slide here. Quote, "Evidence examining the effect of marijuana on diabetes, dyslipidemia, acute myocardial infarction, stroke, or cardiovascular and all-cause mortality was insufficient. Although the current literature includes several long-term prospective studies, they are limited by recall bias, inadequate exposure assessment, minimal marijuana exposure, and a predominance of low-risk cohorts," end quote. Clearly, there's more work to do here. Insufficient data does not mean absence of risk. Cannabis is not entirely benign. We know there are adverse effects, especially when combusting cannabis, and especially in patients with existing cardiovascular conditions. Now, that said, I'm not convinced that the research warrants the excessive hand-wringing that we've witnessed in the media since the American Heart Association released their statement. We're about 30 minutes in, so I want to pause here just to ask if there are any questions or comments. And again, you can feel free to use the chat or you can raise your hand. Okay. And when I say raise your hand, I mean click the raise your hand button in Zoom. Otherwise, I won't see you. Okay, let's move on. Cannabis and hypertension. Does cannabis cause or contribute to hypertension? So I'm going to back up one minute. There's a question in the chat. Where can I find future dates to share on social media? Oh, we'll April, we'll share that information at the end of the webinar. So hypertension is high blood pressure. It's the most common cardiovascular disease. Blood pressure is the measure of force of blood pushing against your artery walls. And over time, high blood pressure can damage arteries, and it can lead to life-threatening conditions. Now, we know that Poor diet, stress, physical inactivity, alcohol, and tobacco use can increase the risk of developing hypertension. In the US, there's approximately 30% of adults have high blood pressure. So it's kind of an alarming amount. Blood pressure is measured using two numbers, systolic pressure and diastolic pressure. The higher of the two numbers is systolic pressure, and this represents the force in the arteries when the heart beats. And the second number is diastolic pressure, and this represents the pressure in the arteries when the heart rests between beats. So blood pressure is going to vary in a healthy adult. It's going to rise and fall with changes in activity or motion. Normal blood pressure, probably we've all heard this, is 120/80 in a healthy adult. High blood pressure is diagnosed after two blood pressure readings at or exceeding 130/80. So does cannabis cause high blood pressure? Well, there are studies that suggest that occasional cannabis users, and these are people who are smoking THC, might experience mild and dose-dependent increases in blood pressure and heart rate about 10 to 15 minutes after cannabis inhalation. Experienced cannabis users can actually develop a tolerance to these side effects. There's a study that surveyed data from over 12,000 US adults. It suggested a modest association between recent cannabis use and increased systolic blood pressure. The data revealed no association between cannabis use and diastolic blood pressure levels. And these researchers detected a statistically significant association between recent cannabis use and high pulse pressure, but no association between cannabis use and hypertension or pre-hypertension. Finally, the study revealed no association between lifetime history of cannabis use and hypertension. Conversely, there was a different study, a small double-blind study with 9 healthy men, so very small, and it suggested that 600 milligrams of CBD increased heart rate, but decreased systolic blood pressure. Can you use cannabis if you have high blood pressure? Well, as mentioned previously, using cannabis, specifically THC, can affect your blood pressure. The effect depends on the amount consumed, the route of administration, your experience with THC, your underlying health. We know that in animal models, there's evidence of THC producing both vasodilation and vasoconstriction, sort of depending on the route and also depending on where you are and the duration of effects. And then strangely, your posture can impact the effect of THC as well. There was a study with healthy volunteers who were administered THC. Their heart rate increased, but their blood pressure decreased. So probably they had tachycardia and vasodilation. In studies where participants were administered THC while lying down, these participants had elevated blood pressure, but when they stood up, their blood pressure dropped suddenly and they experienced low blood pressure. And this is called orthostatic or postural hypotension. And this can actually be kind of dangerous in some patient populations, especially seniors, because a sudden drop of blood pressure can cause dizziness, and sometimes it can even cause fainting. So what's the answer? Can you use cannabis if you have high blood pressure? Well, the answer is I don't know, and it depends. The route will influence your experience. We mentioned earlier that combusted smoke contains carbon monoxide. So if you're already suffering from impaired cardiovascular health, like high blood pressure, you should probably avoid smoking. The dose will likely influence your experience. You should be working with a qualified healthcare professional to determine if or whether you can use cannabis, and if so, how much and what route. So we've talked a lot about potential risks of using cannabis with cardiovascular disease. We know that cannabis can be an effective treatment for symptoms related to a very broad range of conditions and disease. Recall that the American Heart Association stated in their report that, quote, cannabis may have therapeutic benefits, but few are cardiovascular in nature, end quote. So it begs the question, are there any cardiovascular benefits to using cannabis? There are some preclinical studies that suggest that a very low dose of THC may be cardioprotective on experimentally induced myocardial infarction. Some patients with angina that's based on spastic contraction of the coronary arteries might benefit from the antispasmodic effects of cannabis. Also, cannabinoids reduce platelet aggregation and can reduce the tendency of blood to form clots. Now, my colleague, Eloise Thiessen, she suggests caution here. When I was researching this topic, she noted that this doesn't mean that cannabis is a blood thinner that's similar to warfarin. There are two main types of blood thinners. There are anticoagulants. These are like warfarin or Coumadin. These slow down your body's process of making clots, but there are also antiplatelet drugs. These are things like aspirin and some cannabinoids. These prevent blood cells called platelets from clumping together that will subsequently form a clot. Also, cannabinoids might influence the production of C-reactive proteins. So C-reactive proteins are made in the liver and they're sent into the blood as a response to inflammation. In fact, inflammation can be measured by the levels of C-reactive proteins in the blood, and higher levels of C-reactive proteins are associated with a higher risk of heart attack. Cannabinoids are potent anti-inflammatories, and they might reduce the levels of C-reactive proteins in the blood. Metabolic syndrome is a group of comorbid conditions that increase the risk of heart disease, also stroke and type 2 diabetes. These conditions include increased blood pressure, high blood sugar, excess belly fat, and high levels of cholesterol and triglyceride. A study published in 2016 analyzed over 8,000 subjects. These subjects were aged 20 to 59. They were exploring the relationship between cannabis use and metabolic syndrome across stages of adulthood. So these researchers concluded that current cannabis users were 54% less likely than subjects who never use cannabis to present with metabolic syndrome. And they concluded that current cannabis use is associated with lower odds of metabolic syndrome across emerging and middle-aged US adults. It should be noted that the adverse cardiovascular effects of cannabis are almost always associated specifically with THC. In contrast, CBD might reduce heart rate, blood pressure, anxiety, and stress. And high blood pressure is the leading risk factor for heart disease, and stress can exacerbate high blood pressure. There was a study in 2008 in rats that suggested that CBD can reduce increased blood pressure and heart rate in response to stress in a dose-dependent manner. So these researchers noted that CBD also decreased anxiety, and that all of these effects were likely mediated by the 5-HT1A receptor activation. And CBD is an agonist at 5-HT1A. 5-HT1A receptors are serotonin receptors. They're receptors that are located in high densities in the central nervous system. 5-HT1A receptor activation can decrease blood pressure, it can decrease heart rate, can also decrease body temperature. And again, CBD is a potent agonist at 5-HT1A receptors. So is CBDA. In a 2017 study, healthy human volunteers were subjected to stress and given a dose of CBD. They had statistically significant lower blood pressure compared to the volunteers who were given a placebo. I do want to point out that not only did the American Heart Association publish the report last year in August of 2020, they also published a press release at the same time, and it was titled, quote, "Cannabis use shows substantial risks, no benefits for cardiovascular health, more research is critical," end quote. If you actually read the full press release, they also state the following, quote, "Studies on CBD have found associations with reduced heart rate, lower blood pressure, increased vasodilation, and potentially reduced inflammation. Inflammation is linked to atherosclerosis, the slow narrowing of the arteries that underlies most heart attacks and possibly strokes," end quote. So even in their own press release, the one in which they state that there exist no benefits of cannabis for cardiovascular health, the American Heart Association lists benefits of cannabinoids for cardiovascular health. Okay, now I'm going to reiterate at this point that I am not a healthcare professional. And for the rest of this presentation, I am going to lean on some of the work and observations of my colleague, Eloise Thiessen. She's an advanced geriatric nurse practitioner. She's the president of the American Cannabis Nurses Association. And again, I'm going to be relying on her clinical observations and experience for a good portion of the rest of this presentation. So some of you might have heard that there are clinicians that state that warfarin use is contraindicated for use in patients using cannabis. Cannabis use can clearly affect INR levels, and there's a very narrow therapeutic window with warfarin. So patients who are using cannabis and warfarin, they have to inform their healthcare provider that they're starting cannabinoid therapy, and that their INR levels will likely fluctuate during their initial cannabinoid therapy phase. And this is the phase where patients are trying to find their correct cannabinoid dose. After patients find the right cannabinoid dose and make some adjustments to their warfarin dose, typically their INR levels do often stabilize. So INR stands for International Normalized Ratio. Now, doctors will measure a patient's INR level during a test called the PT-INR test. And it just measures the time it takes for a patient's blood to clot. And the test ensures that patients are receiving the correct dose of warfarin. There was a case report that was published in the University of Alabama, published by the University of Alabama in 2017. It described how physicians can successfully manage cannabinoid drug interactions, even when they're working with a medication, and in this case, warfarin, that has a very narrow therapeutic window. Warfarin is commonly prescribed as a blood thinner. It's sold under the brand name of Coumadin. Among adults 65 years and older, warfarin was one of the 15 most common drugs, responsible for an estimated 60% of the emergency room visits for adverse drug events. So this case report describes a patient who was taking 7.5 milligrams of warfarin each day. The patient then began using Epidiolex and titrated up to a target dose of 15 milligrams per kilogram of body weight. And the patient did that over a 1-month period. So Epidiolex is a plant-extracted pure CBD solution. I don't have the exact weight of the patient, but if we assume that they were 150 pounds, that's roughly 70 kilos. That's about 1,000 milligrams of CBD per day. That's a pretty large dose. Now, CBD is an inhibitor of the enzymes that metabolize warfarin. These are cytochrome P450 enzymes, likely CYP2C9 and CYP3A4, and possibly CYP2C19. So consequently, CBD potentiated the effects of warfarin in the patient and necessitated a lower warfarin dose. So initially, these clinicians decreased the patient's warfarin dose by about 20%. The patient goes on, or the report goes on to describe how the patient had to increase the dose to get closer to the target dose of CBD, and it was increased up to nearly 35 milligrams per kilogram of body weight, so almost another 2 times. But the clinicians were successfully able to monitor the warfarin concentration levels, and eventually they set the final warfarin dose at about 70% of the original dose. So cannabis can be used with warfarin. But again, these patients need to be communicative with all of their healthcare professionals, with their Coumadin clinic, with their cardiologist, with their cannabis healthcare professional. So if you are a clinician working with patients, always assess for chest pain, edema, heart palpitations, arrhythmia, hypotension, and orthostatic hypotension. Also be aware that many cannabinoid naive patients might report tachycardia. It's a common side effect of using cannabinoids, but it's also an adverse effect that can resolve after repeated use. If you're working with geriatric patients, especially patients using hypertensive medication, ensure that you monitor orthostatic blood pressure and always include precautions and safety recommendations in the treatment plan. And you should probably avoid starting cannabis therapy for patients who have unstable or newly diagnosed atrial fibrillation or recent myocardial infarction. And we didn't really talk about AFib today. I don't really intend to. There is information about AFib in our cardiovascular module available at Radicle Health. If you're a patient with existing cardiovascular disease, you should know that the risk of a heart attack when using cannabis is likely similar to the risk of a brisk walk or to sexual intercourse. You should always notify your cardiologist, your Coumadin clinic, all of your healthcare providers before beginning a cannabis regimen. Also, always work with an experienced and qualified cannabis healthcare professional. And of course, you want to start low, go slow, but consider also starting with a non-impairing cannabinoid. You could start with CBD or CBDA or CBG. Always monitor and record your side effects. These might include increased heart rate. If you're taking your own blood pressure, note any increases or decreases in blood pressure. If you have dizziness, note that. Take note of any potential drug-drug interaction. So for example, if you're taking a prescription drug, does it feel stronger or weaker when you use it in conjunction with your cannabinoid medicine? And then finally, if you're using Coumadin, keep your cannabis dose consistent if you can to help avoid fluctuating INR levels. I did notice that there are some people who joined us just a couple of minutes ago. We did start at 4 p.m. Pacific, 5 p.m. Mountain. I know there's been some confusion in the past about that. We are recording this, so we'll post the recording so that you can review the entire presentation. I want to remind everyone that Radicle Health has an array of curriculum options at a range of price points and for students and working professionals. Whether you're helping customers make good product choices, or if you're treating patients, if you're advocating for social change or using cannabis yourself, you need evidence-based, factual information about cannabis. Radicle Health curriculum is up to date, it's comprehensive, and it's informed by both clinical expertise and by instructional design expertise. And also, before I open for any further questions, I want to acknowledge the programs that the Community College of Denver is creating for students. They are starting the design of 2 undergraduate cannabis programs. I've seen some of the proposed curriculum for these degree programs. They're very exciting, they're very progressive, and I think that these degree programs will provide students with very marketable skills and knowledge for entry into what we all recognize as an exciting and dynamic industry. So I thank you for your time and for indulging me this afternoon and this evening. We have plenty of time for questions. I do want to hand it back over to Dr. Obeidi to talk a little bit more about maybe the Denver program.
So Timothy, I wanted to thank you. So please accept our sincere appreciation for this informative presentation. I know that our provost and vice president is with us tonight. Ruthann, is there anything you would like to say?
Thank you so much. I'm just so grateful to have expertise like Tim's, like Dr. Byars here in our partnership. It's been so great listening. I've learned a great deal, and I'm always really very grateful to our industry partners and who are willing to engage our community, answering questions and helping us all learn a little bit more. So thank you so much, Tim. I really appreciate your time tonight.
Thank you. I do want to clarify that I am not a doctor.
Well, I will clarify as well. I am not either, but I'm often called one. So there you go.
We do have a little bit of time. Are there any questions? I've looked in the chat. I don't see any questions in the chat. Any questions from the group?
So Timothy, I wanted to take this opportunity to announce our next presentation on Cannabis 411, Make Data-Informed Decisions. And this workshop will offer insight into the cannabis community in Denver via data collected from LEAF 411 hotline. And our presenter is the CEO of LEAF 411, and she's an RN. Her name is Catherine Golden, and I think I see her. Are you with us, Catherine?
Yes, I am.
So please allow
Can you hear me?
Yes, please allow me to welcome Catherine Golden. She is the facilitator of our next workshop. Catherine, do you want to share a few words about your next workshop?
Sure, I'd love to. And thank you, Dr. Obeidi, and especially thank you, Timothy. I mean, we actually partner with Radicle Health. I was excited to hear his presentation. I mean, most comprehensive. It's just wonderful. So thank you for allowing both Radicle Health and LEAF 411 to present a workshop. So we really appreciate that. And yeah, you know, my workshop is going to be giving you an insight on the cannabis consumer. We collect non-identifying data in our first program we launched. We're a nonprofit, a 501c3, and we take calls all across the country. So it's going to be exciting to share with everyone who the cannabis consumer truly is by our data we collect across the country, and even outside of the United States, we get people that ask this question. So that's what I'll be presenting next month. So thank you.
Thank you, Catherine. And I put the link to register in the chat area.
Fantastic. Don't miss Catherine's presentation. Leaf 411 is a fantastic organization. We want to support them as much as possible. There are some questions coming in to the chat. I will go through them and try to answer them as best as I can. Are there current studies that you know of underway for cardiovascular health and cannabis? Probably. If you go to clinicaltrials.org, I think, or .gov, you can actually put in some simple keywords and find out what clinical trials are occurring right now and at what stage they are at. So I recommend that you do that. I think it's clinicaltrials.gov. Let's see. When will we receive the link? We'll send out an email to point to the link. We'll likely just put it out on our Radicle Health YouTube channel. I'd like to find the link about the study that physicians can use to help patients using cannabis. There are lots of studies, I think, that you can probably reference that can help clinicians help patients using cannabis. I do, obviously, I recommend Radicle Health Curriculum. I also recognize the person who posted this question as one of our former students. So hi, Cynthia. I tend to rely on PubMed.gov. There is a new, there's a new website that's out that just came, that was just launched. It's called Cannabis, and it's a fantastic resource. I've been using it to do my own research. And it's basically, you can select a condition or you can search by keyword, and you can get a sense of what kind of medical literature and studies are out there for a specific condition or disease. Are there any studies in regard to vaping cannabis? Yeah, remember that whole vaping associated lung injury epidemic that we had? So I'm sure that there are continuing studies that are associated with vaping cannabis. We know that vaping is inherently safer than combusting cannabis flower, just because you're not creating those carcinogens, those tars, carbon monoxide. And I'm sure that there are studies. Again, if you go to clinicaltrials.gov, or if you go to PubMed.gov or Cannabis, you can probably find some of the existing medical literature that's out there. Are you following any of the research on potential drug interactions for the treatment of cardiomyopathy? No, I don't know of any. So I would recommend that, again, use some of the resources that we've mentioned previously. So I don't think I'm much help there. What seems to be the issue with AFib in cannabis? Is it related to increased tachycardia? The data is actually mixed. So there's a couple of case reports where the clinicians they suspect that maybe the AFib was, these are really young people, so it's kind of unusual. So they're suspecting that it might be triggered by cannabis use. There's a large study, I can't remember the group, Healthcare Cost and Utilization Project, something like that. This was from 2014. They looked at two different groups. I think there were like over 3,000 patients, and they compared two groups with AFib and control groups, and they stated that cannabis users were less likely to have AFib. So the research is it's insufficient, basically. This is not about cardiovascular system. However, I work with children with special needs. I'm curious if there will be any info concerning pediatrics and cannabis benefits. I don't know of anything that's currently scheduled with Community College of Denver. Dr. Obeidi, do you know if there are any topics where we cover pediatrics?
I'm thinking back. I think we cover a wide variety of patients, but I'm not sure. I need to go back to our curriculum and see if we cover pediatrics.
So one clinician who I would recommend is Dr. Bonnie Goldstein. She's down in Southern California, and she exclusively works with pediatric patients, most of whom have some form of epilepsy. But I would recommend her website. I know she's published a couple of books as well. So Dr. Bonnie Goldstein, that's a reference that you might pursue. Are continuing education credits available for this webinar? I don't think so. We do offer them through our Radicle Health curriculum, but I don't believe we're offering any for this webinar. As an aside question, I want to have a mammogram done and saw 3 men getting mammograms. I asked the nurse and she said that cannabis can lead to I don't know the name of the condition, but basically can cannabis cause men to grow breasts? I think that is a constructive cannabis narrative, much like the cannabis causes murderous insanity and cannabis causes amotivational syndrome. I think that the literature there is very dubious. We're at the top of the hour. I do want to pause just briefly to see if there are any other questions. Again, thank you all. I know it's evening on the East Coast. Thanks for spending your evening with us tonight. I'm going to reiterate that for those of you who just joined or who joined closer to the top of the hour, we did start at 4 p.m. Pacific, 5 p.m. Mountain, and we are recording this, so we will post the recording and send out information about how to access that recording. So for those of you from Community College of Denver, thanks so much for hosting this workshop. Thank you all for attending, and we'll look forward to seeing you all in a future Community College of Denver workshop or Radicle Community webinar. Take care.
Thank you, Timothy, and thank you everyone for attending. Goodbye.